Hello, welcome to ERMP and beyond. Today we will discuss a case scenario related to pathophysiology and clinical implications of the renin-angiotensin system, specifically the renal effects of AKI inhibitors. Before starting the case, please subscribe, like, and write me your feedback in the comment section. Let's jump to the case without further delay. A 40-year-old man with type 1 DM and 24 hours urine protein of 1 gram is started on enalapril 2.5 mg POBID to slow the progression of kidney disease. Repeat creatinine after 2 weeks of treatment showed increased from a baseline value of 1 mg per deciliter to 1.2 mg per deciliter. What is the most likely explanation for the increase in creatinine value? A. Method of serum creatinine assay. B. Reduction of GFR. C. Reduced tubular secretion of creatinine. D. Increased muscle wasting. Today, we delve into the physiology of the renin-angiotensin system, a remarkable cascade that plays a pivotal role in regulating our blood pressure and fluid balance. This system's finesse lies in its ability to respond to the body's needs with precision, a dance of molecules choreographed by nature's own hand. The juxtaglomerular cells, nestled around the afferent glomerular arterioles, are the sentinels, releasing renin, a proteolytic enzyme, when they sense the whisper of reduced kidney blood flow or the urgent call of increased sympathetic tone. This release is the first note in a symphony of reactions that maintain the delicate equilibrium within our bodies. Renin, once liberated, seeks out angiotensinogen, its partner in this biochemical ballet, transforming it into angiotensin 1. Angiotensin 1 is a precursor, a promise of what is to come, as it undergoes a metamorphosis under the influence of several enzymes, including the well-known AKI and the less celebrated chymase, to become angiotensin 2. Angiotensin 2, a molecule of great consequence, finds its purpose in engaging with two major receptors, aptly named angiotensin 1 and angiotensin 2 receptors. The interaction with angiotensin 1 receptors is particularly profound, leading to a significant constriction of the efferent arterioles. This constriction is no mere tightening, it is a calculated move to increase the interglomerular pressure head, ensuring that the filtration rate remains steadfast, a testament to the body's resolve to maintain homeostasis. Conversely, the stimulation of angiotensin 2 receptors seems to play a counterpoint, producing effects that appear to temper the actions on the efferent arterioles. This delicate balance between the two receptor pathways exemplifies the body's wisdom in preserving equilibrium, even at the microscopic level. Angiotensin 2, ensuring that our blood pressure doesn't fall too low. It acts as a systemic vasoconstrictor, narrowing the blood vessels, which might sound concerning, but it's a necessary action to restore blood pressure to normal levels. However, angiotensin 2 doesn't stop there. It has a preferential target, the glomerular efferent arteriole. By constricting this specific arteriole, angiotensin 2 ingeniously increases the hydrostatic pressure within the glomerulus. This is not just any increase, it's a strategic move that boosts the glomerular filtration rate, which is pivotal for our kidneys to filter blood efficiently. The filtration fraction is the ratio of GFR to renal plasma flow. With the increase in GFR and a decrease in renal plasma flow, courtesy of angiotensin 2's actions, the filtration fraction naturally rises. This is our body's way of optimizing kidney function, even under the stress of low blood pressure. But what happens when we introduce AKI inhibitors, like enalapril, into the renin-angiotensin system? These agents are game changers. They decrease angiotensin 2 levels, which reverses its effects. The loss of vasoconstriction leads to an increase in renal plasma flow, and without the preferential constriction of the efferent arteriole, GFR decreases. This dual action results in a decrease in filtration fraction. Clinically, this is significant. The initiation of AKI inhibitors can cause a mild increase in creatinine levels, a marker of kidney function. While this might sound alarming, it's a transient effect, reflecting the body's adjustment to the medication. ACE inhibitors and angiotensin receptor blockers are not merely medications, they are guardians for our kidneys, especially in the battle against diabetic kidney disease and other proteinuric kidney diseases. They stand as sentinels, lowering blood pressure, diminishing proteinuria, and decelerating the progression of kidney disease. Moreover, they are likely to reduce cardiovascular risk through mechanisms that transcend mere blood pressure control. In the realm of kidney diseases characterized by proteinuria, ACE inhibitors and ARBs are recommended even in the absence of hypertension, a testament to their significance. They can be employed alone or synergistically to curtail proteinuria in patients, irrespective of their hypertensive status. Enalapril, a stalwart among ACE inhibitors, is utilized in the management of hypertension. As described earlier, it operates by thwarting the formation of angiotensin II from angiotensin I, thereby disrupting the renin-angiotensin-aldosterone cascade, a remarkable feat indeed. Let's consider the physiological nuances. When the juxtaglomerular apparatus senses states of low volume or pressure, it orchestrates the release of renin. Renin then transforms angiotensinogen, produced by the liver, into angiotensin I, which is subsequently converted into angiotensin II, primarily in the lungs, through the action of ACE. An initial decrease in GFR may be observed, a consequence of reduced pressure, particularly in patients with pre-existing kidney conditions. However, it's crucial to recognize the long-term benefits. Despite this initial decline, ACE inhibitors are a beacon of hope, safeguarding kidney function over time by reducing proteinuria and slowing the inexorable march of chronic kidney disease. Let's break down this question about the patient's creatinine levels. The question asks about a 40-year-old man with type 1 diabetes and some protein in his urine. This suggests he might have diabetic nephropathy, a type of kidney damage that can happen with long-term diabetes. He was prescribed enalapril, a medication that helps protect the kidneys in this situation. Now, after 2 weeks on enalapril, his creatinine level went up. Based on our discussion, reduction of GFR is the correct answer. Let's look at why the other options are less likely. Option A, method of serum creatinine assay. While it's true that different labs might have slightly different ways of measuring creatinine, these variations are usually small. They wouldn't typically explain a noticeable jump in creatinine levels like this. Option C, reduced tubular secretion of creatinine. The kidneys have tiny tubes called tubules that help fine-tune what substances stay in the blood and what gets excreted as urine. Some creatinine is secreted directly into these tubules. ACE inhibitors like enalapril don't have a major impact on this particular process. Option D, increased muscle wasting. Creatinine is produced by our muscles. So, if someone was experiencing significant muscle breakdown, their creatinine levels might actually go down. Also, muscle wasting isn't a common side effect we see when someone first starts taking enalapril. In summary, while a small increase in creatinine after starting enalapril can be concerning, it's often a temporary result of the medication's beneficial effect of lowering pressure in the kidneys. It's essential to monitor kidney function closely in patients with diabetic nephropathy, but this initial increase doesn't necessarily mean the medication is harming the kidneys. That's a wrap on our discussion about the overview of the renal effects of ACE inhibitors. I trust you found the insights valuable and empowering. If you appreciated this content, please support our channel by hitting the like button, subscribing for more updates, and sharing this video to spread awareness. Until next time, stay informed and stay healthy.